Hello, everyone. I'd like to let everybody know that this meeting is going to be recorded, so just as a heads up.
Okay, it looks like everyone's here, so I'll just get started. Hello, everyone. Welcome to the Obesity Treatment Analysis Advisory Group. This is our fifth meeting. Like Remy mentioned, the meetings are recorded and a recording will be posted on the webpage for the advisory group. And like normal, just use raise hand function or chat to pose questions. The goal of today's meeting is to go over the questions, comments, and concerns that we received about the draft report. I tried to compile a list of the questions and comments we received, and so I have them on the slides, so I will put the relevant slide up when we get to those questions. I don't think we'll be able to get through everything today, but for what we aren't able to address in today's meeting, we'll make sure to follow up about over email. Does anyone have any questions about that? Okay, I will hand it over to Casey from Milliman, and I have our first comment / question up on the screen, if everybody can see that.
Yes, the first question is about the diabetes population. So we excluded only the population of people who are currently taking a GLP-1 from the analysis, not all people with diabetes. And the objection is that the folks with diabetes already have coverage, and so they should be removed from the analysis. And we are going to keep the methodology the way that we have it. And the reason for this is that the dosing to be using it for weight loss reasons is going to be different than the doses used for diabetes. And so the access to the drug for weight loss purposes would come as a result of the mandate. They would not already have access to the weight loss doses. Carol, do you have anything to add to that? And for the group, Dr. Carol Bazell is here. She's a clinician who helped with the analysis plan for this project.
Yeah, so I think I would hold with what Casey's explanation is. In some cases, payers, in order for a patient with diabetes to be treated with GLP-1, in fact, like require a person to have been on another drug or potentially not have been successful in that other drug. That's part of the reason. And then most sort of like in our sort of look at commercial plans, we can see that most of them limit the amount of the GLP-1 that can be prescribed monthly for diabetes to the maximum doses specified for diabetes. For the weight loss drugs, the typical sort of maximums may be twice what we see for diabetes. And we know, so the sense is that there may be patients who are not taking GLP-1 now who would then have new access to weight loss drugs with this bill at doses that are, have been most likely to lead to substantial weight loss. And so there is an expansion of access to the full dose range that is commonly required for weight loss, for the maximum weight loss. So those are our reasons for sort of retaining the people in the population who have diabetes, are overweight or obese, but are not currently on a GLP-1.
I see Greg has a question, and then we can go to Emily.
Yeah, I do. Hi, this is Greg from Eli Lilly. thanks for that explanation. There was one point that you made on that I didn't quite understand, which was patients with diabetes, if they were going to go on to a diabetes GLP-1, they would more likely have to fail.
Walmart. We're open, dude.
They would more likely have to. Hold on, I'm just. Okay, would more likely have to fail an older a diabetes drug that they're already on. So this cohort of patients for this analysis would have people with diabetes and also presumably potentially on some of those other diabetes drugs. Is that correct?
I think that's true, right? These patients
Okay.
the patients with diabetes who are not on GLP-1 might be on another drug for diabetes. There are still some payers, despite the evolution of guidelines. When we look and we scan policies, there's no systematic way to see the details of those policies.
Yeah.
We see that there's coverage of GLP-1s. There may be some constraints upon the circumstances for the coverage.
But the rate of uptake that's being applied in this analysis is assuming that every single person with diabetes who might actually go on to a diabetes GLP-1 would actually go on to a weight loss obesity GLP-1. Is that correct? Mm-hmm. And so it's not permitting people with diabetes to escalate to a diabetes GLP-1.
So under the expansion of coverage, there is a rate of uptake, I believe, being applied in patients with diabetes. You're saying that the part that's not contemplated here, and again, this is this is a point that I hadn't thought about specifically before. If you have diabetes and you're in GLP-1, there could be a set of people who are on a GLP-1 for diabetes that are at some dose, and in theory, they could switch agents to a weight loss drug in order to like escalate the dose. Is that the point? Is that what you're asking about?
No, I'm actually
or not, or you're asking something else?
No, I'm asking something else. There is no estimate of what a population with diabetes would go on to a weight loss GLP-1 because all studies exclude patients with diabetes from the obesity analysis, especially the studies that have been referenced here. And so another point is that this study is only looking at the adherence and persistence of people with obesity using an obesity GLP-1. Adherence and persistence is higher for patients with diabetes, and that is not being accounted for in here. So the issue that I've taken with this is that many of the methods that are being used here are supported by research that has excluded patients with diabetes.
Understood.
By including that here, you're not including the effectiveness, the adherence, the utilization patterns for people with diabetes at all. And then I would still want, I for sure want to be on record that GLP-1 use for people with diabetes is a covered indication. And that's why these studies have excluded people with diabetes. And that's why the Medicare Bridge program also excludes people with diabetes because diabetes uses of GLP-1s is a covered indication.
I'll just offer, we do a whole set of analyses, and I can absolutely say in the commercial claims proprietary database Millman has, which includes tens of millions of lives, we see people with diagnosed diabetes on branded weight loss drugs. I hear you that they have been excluded from studies examining the impacts of weight loss GLP-1s, and I understand your comments on the Bridge program as well. You know, we can take this back and think about it. I hear what you're saying, sort of the whole like adherence, like likelihood of success sort of concept. If that were applied to patients with diabetes, your hypothesis is that would look different because of their known patterns of drug use. So understand the point you're making there. And we'll think about the application of, again, we have adapted, I think, sort of in the literature, the clinical trial information, for what we think generally the real world will look like in a modeling exercise, because we don't actually have evidence of sort of what would actually happen that is published. But I hear the point you're making, and we'll take that back and think further on about that. Appreciate
Okay,
your
thank you.
explaining more and with more color.
No problem. One more point, if I may, and I understand what you're saying as well. My understanding of the exclusion criteria that's applied here is that people with diabetes who are on a diabetes GLP-1 have been excluded from this analysis. So this would be people who are not, I'm just talking about the diabetes population for the moment. This would be people who could be treated with diabetes medications, just not the diabetes GLP-1. I understand what you're saying, that some of those might actually be well controlled in their diabetes and go on to a GLP-1 for obesity. Some of those may not be well controlled ultimately and go on to a GLP-1 for diabetes. And so if you're going to apply a uptake rate, it would be helpful if you like to understand how you've sort of modeled out what percentage of those diabetes patients would likely go on to a GLP-1 for obesity, and then what percentage would likely go on to a GLP-1 for diabetes, and then not include that latter part in the cost analysis, if that makes sense.
I understand. You're sort of saying that of the non-GLP-1 users right now in a diabetes population, modeling forward, you would expect there would be some rate of initiation of a GLP-1 for diabetes in that group because they were not well controlled or whatever came up clinically. And so not all of them would fall under the weight loss drug category if they were to initiate a GLP-1, because there's some inherent annual initiation rate of GLP-1s in patients with diabetes. Appreciate that comment. We'll take that back and think further about it. You brought up a number of points about the population, and that's something we can think further about.
Okay, thank you.
Emily?
Thank you. Appreciate this analysis and question. I'm Emily from Northwest Health Advocates, and I'm sorry I missed seeing everyone last week. I was unable to join at that time, so I apologize. I have a more basic question, a version of Greg's question, but the more basic, just for my own understanding. So when we did the baseline analysis for the diabetes population, did we anticipate a ramp in that population at baseline? Does that make sense? Just because over time, as more people become familiar with this drug, there will be, absent any kind of intervention or change in coverage, there would be some uptick, I presume, as the drugs become more known, people go in for their annual visit and ask their doctor about it, et cetera, in the diabetes population. So I'm wondering if that baseline population includes a natural uptick over time at base.
And are you
Sorry.
Are you talking about it? Is there a modeled uptick in the use of diabetes GLP-1s in patients with diabetes?
Exactly.
That's exactly the latter point that we were just
That's what you were just talking
about, right? Casey, you can talk about how that, I mean, that is a point. Can you want to comment on how that's handled right now? And again, that's a point that I think should take back and we'll reflect upon. But that is your point
that's
that
a
you're
piece
raising.
Of what this Greg's second question.
It's the latter part of our conversation there, right? That your belief is there would be a natural increase in the users of GLP-1s for diabetes in patients who have diabetes as they, evolve, clinicians become more comfortable, the patient's clinical situation changes. I'm not sure offhand what the rate of use of GLP-1s in diabetes is, like whether that's increased over time. That's something we can reflect upon. Casey, do you want to address how that is handled now or not in the uptake assumptions for weight loss drugs for patients with diabetes who are not on GLP-1s currently?
So for the folks that are not currently using GLP-1s, that have diabetes, they are included in the study population, and the estimate is of those who are obese, I believe it's 12.7% in the middle scenario will uptake the drugs, and there is ramp up over time within that group to reflect that not everybody's going to go out and start on 1/1. And so that ramp up goes over that 2-year period. We are not considering folks that have diabetes and are, taking GLP-1s for diabetes and their rate of change, because that is already covered under the status quo. So that would be happening regardless of whether or not there was any sort of mandate to cover obesity medications.
Okay, so to make sure I understood, Casey, I think I heard you say that the base does include a natural the baseline does include a natural ramp up among the diabetes population. That's
among the whole population. So everybody is getting that same ramp up. Right.
Okay. Okay, sorry, thanks.
And I think the sort of position that's being stated here is that potentially some of those patients would start on a GLP-1 because of, more information or coverage information, or just a general increase in the use of GLP-1s for diabetes. And that the current estimates don't treat the diabetes patient differently in terms of the percent of them who would be on a weight loss drugs. And that's something we can take back and consider. We fully understand the point that you're making.
Okay. Yeah, thank you. Mine was less a point and more a question. So, but yes.
Or the question that's being raised, or the issue that's being described.
Well, I'm sorry, one quick, I took my video off, I'll do it just this once. I'm in the back of a car leaving the airport in Cleveland, Ohio. You caught me off guard, Carol, with the dosing comment on obesity versus diabetes. That might be true for Wegovy and Ozempic, but Zepbound and Mounjaro have the same dosing schedule. So if there's ultimately a rationale provided in the report as to why the diabetes patients are kept in here, it might be helpful to sort of explain the sort of rationale why somebody with diabetes that's not on a GLP-1 would go on to the obesity version, especially for tirzepatide when the dosing is exactly the same and the diabetes for patient would already have coverage. That's still an important point that I think should be reflected.
Understand that you.
Okay, thank you.
That should be described in more detail. Mm-hmm.
Are there any more questions about this comment? Okay, we'll move on to our next comment question, Casey.
So the paper that we're relying on that estimates the savings associated with weight loss, they have a 5%, 10%, 15%, 20, and 25 percent weight loss with their estimated savings and healthcare costs. And in our analysis, we were assuming the reported 5% value and the reported 10% value. The issue here is that we're saying that people could have 10% or more, and we're using the 10%. So in essence, we're truncating the value. We were unable to find anything within literature that would suggest that had some kind of a distribution that we could use of folks that are using over the course of a year, and then including like the, there's studies that suggest that people also gain the weight back and things of that nature. So it's this is where it becomes a little more art than science. So we pointed to the 10%. We could justify also pointing to the 15%. So that would, because yes, like 10% is the lower bound. But I don't know how, like, at this point, we would be picking a number. It's not going off of a known distribution of weight loss. Um, there's a lot of studies that suggest that, you know, the average is about 15%. And, you know, and then there's lots of caveats that go along with that. It depends on, you know, where they started and how long they were on it. Did they gain it back later and things of that nature? So we could change uh, the point from the 10% number that's in the Thorpe paper, which we've trended forward and so on. We could change that point to the 15% to try to take into consideration that some of these folks might have 20% and 25% weight loss and 15% weight loss.
I'll just remind people we're not modeling over a long period of time. Some of these comments become sort of more like pretty relevant over that, and we don't have an exact weight distribution to start with. So there's some, as Casey said, art here about like sort of just generally what we think is a reasonable assumption over the 2-year period, given everybody's not even starting on. So even though there's people that are persistent, if they're starting later, they won't have that much time in the modeling period. So like, what is the sort of distribution of people that would achieve the higher levels of higher percentage of weight loss given the limited modeling time period?
And also the modeling suggests that the savings are happening in the year in which the savings are occurring. And so, I mean, in reality, it's not that, oh, I lost 5% of my weight, so now I'm $1,300 cheaper. And that's going to happen immediately. So as far as like trying to keep the, like, yes, savings will happen. When will the savings happen? It's unclear, but I would expect it to be on the lower end for the savings to happen immediately. So in the year of weight loss, which is what we are modeling.
So the Gasoyen 2025 study is a real world evidence study that does produce a distribution of weight loss. So there is a distribution of weight loss and they go up to 20%. It's in the supplemental materials for that particular paper. The second point is the Thorpe study does show higher cost savings for people who lose more than 10% weight loss. What I hear you saying is that you don't believe those columns, but you do believe the 10% weight loss cost column. And that doesn't make sense to me.
No, I didn't say that I don't believe the higher columns. What I'm saying is that without a distribution of those who have lost the weight, we are unable to say, you know, is it going to be closer to the 15% number, the 20% number, the 25% number? So based on the research that we have and also adjusting for the fact that the way that we're applying this value is going to be in the year that the savings is occurring, we would want to be more conservative in which values we'd want to say are going to happen in the year that someone is losing the weight.
So the Gasoyen paper is a real world evidence study and they show a 1-year distribution of weight loss. That is in the study and you're already using that reference. So you do have the distribution.
Which study are you suggesting?
It's the Gasoyen 2025. I think it's reference.
No, I can look for it from that.
Yeah.
You said it's in the supplemental materials.
Yeah, it's reference number 44.
And we can certainly look into that and look into applying that that distribution. But I will note that we will be on the more conservative end because we are trying like this. There isn't a very great resource for saying how much are people losing or saving in the year that they're losing the weight. And so, I mean, when most people talk about weight loss, it's over a period of time. and the health benefits over time and what people could be experiencing over a larger window. But I mean, in this case, we're talking about someone who might have been on the drug for 3 months, and maybe they did hit 5% of their weight loss, but are we expecting them to, we're saying that they're going to save $700, and it's because that's the value that we have, but it's not necessarily going to line up with the time frame. So we're trying to also be a little bit more conservative in those estimates.
Thank you.
Okay, so we can move on to the next comment. I can pass back to you, Casey.
Yes, so this is citing that we are not taking into account the some of the newest research, and when we include the my computer does not want to. Great. So when we include one of the newer papers with we will be increasing the year 1 effectiveness rates, accounting for the persistence for the middle scenario for the GLP-1 weight loss drugs at 5%, or for the 5% weight loss, we'd be increasing the middle and high scenarios to 16 and 21% from the 15 and 16%. And the 10% weight loss, we would be increasing the real world effectiveness to 15% and 27% for the middle and high scenarios. That's compared with the 13 and 21% as they are now.
I'll just point out that these values will not track what a study showed specifically because we're adjusting the sort of effectiveness rate by persistence. And so we're taking both of those factors. So we essentially have an effective effectiveness rate, which is different than an actual measured effectiveness in a persistent patient. And in the real world, our persistence estimates are lower than clinical trials, for example, and for some of the other reasons. And so that basically creates the metrics you see, who achieved this, you should consider a function of two things: the effectiveness of the drug if you're persistent, and then the persistence in the population who initiates the drug.
Any additional comments or questions? Okay.
Yeah, just on that last point, I would just point out that I understand the difference between persistence in trials versus real world evidence. And I think it's great that you all are referencing some of the real world evidence studies, particularly the Gassian study that I pointed out, which does have the effectiveness distribution and does account for persistence. It's not a trial population, it's a real world evidence population. And then the second study that I think looked closer at persistence was the Prime Therapeutics study that was replicated after the shortages. And so that study is a more accurate reflection of persistence, since the shortage had largely been resolved by the time that study was completed.
Okay, I'll move on to the next question or comment.
So the effectiveness table is, I think this is a matter of clarity. So the rates are additive. So someone could be in when they're there for the first year, some of those people drop out, and so they're no longer included in the second year, and that's what's being reflected there. So it's not a matter of some of the folks not being or being discounted. Like if in year one we have people who are starting, and so they're getting the year one rates, and then in year two, the people who started in year one are getting the year two rate or the year two rates, and then the folks that are starting in year two are getting the year one rates because they're just now starting. Does that make sense?
I'm not sure if it makes sense, but I think if you provide more detail in the report on exactly how those numbers came about, then I think that would be helpful.
Yeah, we can do that.
So our next question is again about like persistence. I think we touched on some of this, but
I think you already mentioned, Casey, making some adjustments, right, based on the more recent information in your earlier comments.
Right. Is there anything else you'd like to add on that one?
Sorry, I'm just looking at I'm just looking at my notes here too. The only this is the same one. Yeah, it's the Marshall. Gleason was the earlier study. Prime Therapeutics, and Prime Therapeutics is primary source at the time of published real-world use of these products. The Marshall study.
Right. So in considering the Marshall study, that's where we increase the effectiveness, the assumed effectiveness rates for the folks that are meeting the 5 and 10% weight loss thresholds. So again, for the first year, the middle scenario, we're going from 15 to 16% for the 5 effectiveness for the 5%, and 16% of folks are going to reach the 5% threshold of weight loss. And 15% will reach the 10% threshold. And then on the high scenario, it'd be 21 and 27. And those values are higher than what we currently have assumed in the version that you've all seen, which is 15% and 13% for the middle scenario, and then 16 and 21 for the high scenario for the percentage of folks who achieve 5 and 10% weight loss.
it looks like Greg may have dropped off, but I'm sure if he has additional questions, we can also he'll follow up if he does. I can move on to our next comment.
Okay, so this one is something I think we'll clarify within the language. So the 12.7% is the percentage of people we think that may qualify for the drug. The 12.7% is those who would actually use it. And so we have a range of scenarios around the folks that might use that. The CDC estimates and our commercial population estimates are different because the commercial population has a different demographic distribution than the CDC, which is everybody. We're looking at the commercial population, which wouldn't include, seniors and like folks on Medicaid, things of that nature. So the populations are just different. And so what we did is we applied the CDC demographic distribution, or excuse me, the CDC obesity weights to a commercial demographic distribution based on Milliman's internal research to come up with, and adjusted it for, Washington specific values to come up with the 25 to 30%, depending on which line of business they were enrolled in. So there's a few different pieces that are going into that 25 to 30%. And that's why those three values differ. We could certainly add more clarification to that within the report.
Any questions about this? Oh, Gina.
Sorry. Thank you. I think that's really what it is. It's just, you're looking at these high numbers and you're like, well, 12.7, how did we get there? And I know that if I recall from last week or the last meeting, I think it also reflected like the health status of Washingtonians, like, right? Isn't that also another thing that was pulling it down?
Right. So the Washington is healthier than the national population.
Right.
Right.
Okay. So thank you. I appreciate you explaining that.
Yeah, and we'll definitely add more color to the report on those points.
Bring on to the next comment.
This one I feel like we went over in our first meeting, where we were talking about the offsetting values, and we will add more clarification to that within the report. Is there more clarification that you'd need right now live? But I feel like we discussed this one.
Yeah, no, I'm sorry. This is a question I had as well. I just felt like at the end of the executive summary, there was just a statement that said, that the savings wouldn't be fully offset, and just having those numbers a little bit closer might just give a little bit more context. It's not that the data is missing; it's there. It's just that it's presented so much, several pages earlier. So when you read that like final paragraph, you're like, now what are we talking about? So that's all
Okay.
that was. Yeah, no, it's not missing anything at all. So
Sure. Next comment.
Yeah, I believe we discussed this one in the first meeting as well, and this is poor language. So it's to the point that we're trying to make is that it will not just be the obese population that we think that the carriers would decide to cover. They would expand it to the overweight with at least one comorbidity, even though the proposed mandate would not include that population. And the reason for that would be so that they could maximize the rebate potential. So manufacturers might provide a larger rebate if they cover all of the FDA indications and not just carve out just the obese piece. And so we think that those rebates in total that would be received would be greater than if just the piece that of adding the overweight with a comorbidity population to the number of users. So so as we were discussing last time, you might say add 10 users for the cost of the drug, but then you're getting 100,000 people are now getting a rebate that's more than the cost of the drug for those additional 10 people. And so we will clarify within the language so that hopefully it's clear that we're not talking about the rebates offsetting the total cost of mandate, but just for that those marginal folks.
thank you. That I just wanted to make sure that you did talk about that, and I just wanted to make sure because it was very helpful when you explained it the first time.
Thank you. Yeah, this is another one that will clarify. So the premium, or the carrier is not going to be saving premium. They just won't be paying that in dollars to the it just won't be paying for the services to occur. And so so premiums will be lower, but the insurer will also not be paying for services that never occurred. So that's kind of the point that we're trying to make there, and we could certainly make that language more more clear.
Thank you.
I think at least the second part of this is like the 12% question again. I think it's just generally more clarification would just be helpful for people to understand what you're referring to. Any additional comments on this?
Yeah, the 12.7, I believe that report is published, so it should be sourced, and if it's not, well, I'll make sure that the source is there.
Okay. I think we may have talked about this already.
Yes.
Yeah. Okay. I think that's our last comment. Does anyone have any additional comments or questions about the report that we haven't addressed here or haven't addressed over email? Emily?
Thank you. I think is this our last meeting prior to the final?
Yeah. This
Okay.
is our last meeting.
Okay, so I have maybe an overarching question or comment, which is, will the actuarial analysis, when complete, be delivered as a standalone item, or will there be any additional context provided in the final report or information? And what I'm thinking about here is that we have spent a lot of time correctly, a great deal of time in this group thinking about the actuarial analysis and the modeling, which is very important. But there's also a broader public policy conversation that we haven't, to my knowledge, and I have missed a meeting or two, but we haven't broached in the group. And so I'm wondering if it's OIC's vision that there would be any kind of cover discussion or anything like that as part of the report that gives context or information about this information, or whether the report would just be delivered on its own. And I'm thinking as I talk about that in other cases where we have had new treatment innovations that are of significant benefit to patients, but also significant affordability impact, we've had some broader policy conversations along the lines of, we all remember hepatitis C, Sovaldi. There were policy discussions associated with that. And I am not certain if this is the work group where we'll broach some of those conversations. I think not, given the schedule, but it might be appropriate to include in the report some suggestion that those collaborative policy discussions should occur, because I'm looking at this report as it stands, and I'm not seeing a policy choice that is going to produce a clear result for Washington policy, if that makes sense.
So I think generally the plan is just to kind of like present the information that's in the report and not necessarily recommend a choice one way or the other. I know that there also, so along with the report, there'll also be presentation materials. If the legislature wanted us to present on this and had questions, there are going to be like related presentation of materials. And then there's also the WISIP report as well that they're working on. So I would say generally there's like the WISIP report, there's this report, and then there are like relevant presentation materials if we're asked to present on any of this. Does that help answer?
It is, and now I'm really feeling like I've missed something. Did we get a draft of the WISIP report?
I don't think the WISIP report is done yet, but
Okay.
I think the draft is due in August.
Yeah, I can
Okay.
speak to that
Okay.
if you want, Dalika.
Yeah, good.
Okay.
Sorry.
Yeah.
Okay, so thank you for reminding me that there is that additional piece that is still coming.
Yeah, we are actively working in the draft right now to wrap it up. And I believe if I'm remembering my dates correctly, we will send OIC a draft of our report August 10th. And then our final memo is going to be sent on September 1st.
Yeah, that sounds right. And we can
Elise, just
sorry, go ahead.
I was going to say that when this was passed, it also was sent to Sunrise Review for the policy analysis, Emily, that typically is the two-pronged approach that the last couple of years the legislature has been doing, which is that different label, because I think a lot what misses here that I brought up last time is like the impact to the people, right? The people who don't have any real access to obesity treatment are state guaranteed outside of like traditional behavioral health therapy. That was supposed to be happening at the same time, and due to budget cuts, DOH has had to delay that work. So this is going to be coming out in an odd way back to the legislature where it does not have that policy analysis of whether or not it is a good mandate and tweaks to the proposed legislation, but we will have the actuarial work. So we should talk offline because that is going to be an odd way for this to go back to decision makers without that other part of the work.
Yeah. And we can also share WISIP's draft as well with the group, if that would be helpful. And so that the group can provide feedback. Greg?
Yeah, I know that you said that we're not going to have another call. Given that there were a lot of details that weren't included, particularly in how exhibits 15 and 16 were constructed, and Casey, to your point earlier, there's some art to this, and a lot of the art part of it gave rise to some of the assumptions that you're using here, and those seem to be driving the results. I'm just wondering if there's an opportunity once you have a revised report and maybe more of those details are filled in and how you actually got to some of the distributions that you're using. Will there be an opportunity for us to review and provide written feedback, even if we're not having a call?
Casey, we can talk about this offline also, Casey, and get back to the group, but I see your mic is off, so I'll let you go.
Yeah, no, we can discuss offline.
Okay. So as of right now, we don't plan on having another meeting. Casey and I will talk offline about an updated draft and, possibly having like more advisory group feedback, and I'll follow up with everyone on that. The final report is due to us on September 1st, so that's when we'll get the Milliman report as well as the WISIP report. And I will follow up with the group, like I said, about any drafts between now and then and about providing feedback. Does anyone have any questions about any of that?
Dalika, hi everyone. This is Ingrid Ulrey, Senior Health Policy Advisor to the Commissioner, took the place of Jane Beyer, who many of you I'm sure know. I just want to thank everyone for participating, and Dalika, thank you as our Senior Health Policy Analyst assigned to this really important topic. And as we complete the report, I just want to assure everyone that we will be having conversations with the Commissioner, so she's aware of the end result and what was produced, as well as the WISIP report, and then be taking it from there to follow the direction of the legislature to turn this in. And it will be a continued conversation from there. And thanks to our colleagues here from Milliman and the folks who have done the analysis, super helpful. And just recognizing that this is a very complex issue with many trade-offs and a very deeply important for consumers and an area of rapid change in our health system and health policy environment. So yeah, Leke, I just want to recognize that and thank you, especially on a sunny summer Friday afternoon.
Thanks, Ingrid. If there are no other questions, I can give everyone like 38 minutes back or so. Thank you all for participating in the meeting and for all your feedback and your insights. And I will follow up with you all soon. Thank you.
All right, thank you.